Right, Declan, it serves as a theatre partner for this event, and the focus of today's session is chronic disease management in doctors. For this, I would like to welcome our first speaker of today's session, Dr. Pawan S.K. Sir. Sir holds a degree MBBS, MS, MCH, a dedicated urologist with strong clinical and academic credentials. He serves as an assistant professor at JSS Medical College and practices as director at Urological Clinic, where he provides comprehensive urological care with a patient-centered approach. And today, Sir will be talking on the topic silent suffering, managing chronic urological conditions in healthcare professionals. Now, without any further delay, Sir, I now welcome you wholeheartedly to our platform. You can begin the talk now. Thank you.
So thank you, Team Clarinet. It's a wonderful topic that they have chosen for this Doctor's Day. So my topic, the given topic to me is silent suffering, managing chronic urological conditions in healthcare professionals. So me being a consultant urologist in a tertiary care center in a St. John's Hospital, Bangalore, we see a lot of healthcare professionals coming to us seeking uh, medical assistance for their conditions in different parts of their conditions. So we begin with what is the healer's paradox. So we doctors, we treat patients. So healthcare professions are trained to diagnose, treat, and advocate for their patients. Patients' health needs and with expertise and empathy, but not to ourselves. When it comes to their own health, particularly sensitive conditions involving urological disorders, healthcare professions often delay, deny, and dismiss symptoms. So, this is what the double standard is. The same healthcare professional who advises patients to seek prompt care may suffer in silence for months or years due to stigma, embarrassment, and no time. For example, yes, as a urologist, I advise my patients to drink good amount of water, like 3 liters, 4 liters of water, depending on the conditions. But when it comes to me, I'm not able to fit into that criteria of 3 liters because I'll be busy in my own OTs, OPDs. I'm preoccupied everywhere. So I'll be drinking around two liters. Very rarely I touch 3 liters in a day. So what are we going to cover today? First, we'll deal with the scope of the problem, what is its prevalence, and why it is underreported in healthcare professionals. The second would be our common chronic conditions like overactive bladder, lower urinary tract symptoms, chronic prostatitis, or recurrent urinary tract infections, or interstitial cystitis. We'll discuss some amount of it. And what are the barriers to seeking care because of stigma, time, availability, dual role conflict, and collegial embarrassment, and what its impact on professional performance, like the patient safety, and professional burnout, and presentism, and the evidence-based management for these conditions, and creating a supportive culture in an institution, like making proper strategies and support from the colleagues, make it more easy. So, coming to scope of the problem, the urological conditions in healthcare workers, they are more common than we acknowledge. So, nearly 68% of the healthcare professions with overactive bladder delay seeking care for more than 12 months. So, these are the studies which are retrieved from peer-reviewed occupational health studies and urological societies. And there is a 40% of male physicians with low urinary tract symptoms never consult a colleague for their own symptoms. And there is a 3 times higher risk of recurrent urinary tract infections in female nursing staff versus general population. So, 1 in 5 surgeons report that urinary agency has caused intraoperative distress. So these are the actual data that show how it is underlooked, and how healthcare professions are not catering themselves and treating themselves. So the common conditions that we are going to discuss today is overactive bladder. The overactive bladder, for definition, it is accompanied with urgency or urgency incontinency with a frequency more than 8 times per day. and with an nocturia which disrupts sleeps and on-call duties. And the lower nerve tract symptoms, which are most commonly seen in males more than healthcare professions more than 50 years, where they have these voiding symptoms of hesitancy, weak stream, and straining. And they have a storage symptoms of urgency, frequency, and nocturia. And normally is a case of prosthetic enlargement in patients in healthcare professions more than 50 years. The coming to chronic prostatitis or chronic pelvic pain syndrome. So, the definition comes under pelvic pain persisting for more than 3 months. It is often misdiagnosed as musculoskeletal, and it has a significant impact on quality of life and work focus. And there are recurrent urinary tract infections. So if it is more than two episodes of urinary culture proven infection in 6 months or more than three times in a year. These are high risk in female nurses because of dehydration and delayed voiding. And there is a because of this overuse of drugs, there's fluoroquinolones like Ciplox, Levoflox. They're becoming more resistant nowadays. The least topic is interstitial cystitis or bladder pain syndrome, which is very difficult to diagnose. It is mainly the diagnosis of exclusion, where we have a chronic pelvic pain plus bladder pressure syndrome, and it is often delayed diagnosis because it is a diagnosis of exclusion, and nearly 3 to 7 years it might take. Frequently misdiagnosed as UTI or anxiety. So high healthcare professions don't seek help. So, what are the barriers of care seeking among healthcare professionals with urological conditions? The first thing would be stigma and embarrassment. The urological symptoms are inherently private. So because they involve external genitalia and about urination and all. So healthcare professions fear judgment from the peers more than the patients do from the strangers. They always worry what my colleague doctor will feel about me if I say this symptom that I'm suffering from these symptoms and all. And second thing would be the time constraints. So long shift, on-call duties, and patient loads make scheduling personal appointments feel impossible or selfish. So, what is the role conflict? Invincible healer persona. Healthcare professions are caregivers, not patients. If they get any of these things, they feel like it is a professional failure onto them. They take the burden on themselves, and there is no personal doctor. Many healthcare professions lack a regular general practitioner like other patients. So, treating colleagues creates discomfort. They self-diagnose and they self-prescribe instead these medicines and all. The fear of fitness concerns. Worry that disclosing a condition may trigger occupational health reviews or career implications. And the last would be the normalization of symptoms, attributing frequency or urgency or pelvic pain to stress or the job rather than recognizing as a treatable condition. These are the common barriers the healthcare professional feel, and they have these time constraints also. So these are the common conditions that have the common scenarios that have projected here. So, what is the impact of these on healthcare professional performance? So, untreated urological conditions, they have measurable effects on treating patient safety at stake, sometimes even surgeries at a stake. So intraoperative distraction, urge to void mid-procedure increases error risk because the doctor will be subconsciously thinking about his urination or his pain in the abdomen regarding bladder fullness or urgency. So this distraction leads to some procedural errors. The second would be the presentism. But the doctor is physically present but cognitively impaired by the pain and urgency, is not listening to the patient, is thinking about himself. So sleep deprivation from nocturia impairs clinical decision making. So nocturia, if he keep on passing urine for multiple times at night, you won't be getting adequate sleep. As a doctors, we know the sleep is very important in our day-to-day role. So this nocturia leads to sleep deprivation and impairs our clinical decision making and errors in the patient outcomes. So reduce procedural concentration in clinic, theater, emergencies. So irritability and reduced empathy because of this. His own complaints is with reduced empathy. He might shout at patients. He might ill-treat patients, secondary to chronic pain and fatigue. So increased sick leave leading to staffing pressure on colleagues also. So burnout connection, chronic urological pain contributes to emotional exhaustion, a core component of burnout. The healthcare profession managing symptoms likely have 2 times higher burnout scores in occupational studies. And the quality of personal life is also impaired. Intimate relationships, social participation, physical activity, mental health all suffer. The embarrassment prevents disclosure to partners, delaying emotional support. So, what are the evidence-based management? How we treat these symptoms? So, we have behavioral and lifestyle adjustment where we do timed wait, we do timed voiding schedules adapted to shift patterns. There are bladder training where we have heart separation techniques. We teach the patients, and there are pelvic floor physiotherapy for both the sexes, which helps in postponing the urination. And the fluid management is the cornerstone, taking adequate amount of water at a single time and avoiding caffeine, theophylline, or any beverages, which leads to decreased urine production and henceforth balances both intake and urination. So dietary triggers like for interstitial cystitis and bladder pain syndrome, you should avoid acidic foods and the and spicy foods and all. If you take care of these things, it might help in controlling the symptoms of interstitial cystitis and bladder pain syndrome. The sleep hygiene is very important for nocturia management and stress reduction. Mindfulness based approaches, yoga, meditation, running might help you getting some amount of relief in. These are proven relief measures are there with our urological conditions. Pharmacologically, we have mirabagrams, antimuscarinics, beta-3 agonists, alpha blockers, 5-alpha reductase inhibitors, and low-dose prophylaxis we start for recurrent UTI. There are intravesical therapies for interstitial cystitis and bladder pain syndrome. There are muscle relaxants and neuromodulators for chronic pelvic pain syndrome. And there are topical estrogen like for postmenopausal women who is suffering from recurrent urinary tract infection. The procedural surgical highlights would be we have numerous inventions and which are taking place in the urological field. We have sacral neuromodulation, we have posterior tibial nerve stimulation, which have good success rate in overactive bladder patients. Even botulism toxin also helps, and laser TURPs or HOLEP for prostatic enlargement, and flexible cystoscopy for the detection of interstitial cystitis and bladder pain syndrome. And there are post-intervention monitorings, validated scores also, so we can compare ourselves regarding the treatment and after treatment. So the creating a supportive culture is a cornerstone where the institutional policy where we have a dedicated occupational health services for healthcare professionals, which they are confidential, which have a confidential referral pathway to urological clinics, and open dialogue, normalize discussing personal health in peer groups and CME, like what we are doing right now. It's a good way of normalizing things. Normally we should talk about all these things that's been happening with healthcare professionals, which reduces taboo, and it avoids us, and the healthcare professionals become conscious, and they'll sort help, they'll seek for help. The confidentiality assurance should be there, guarantee that accessing occupational health does not trigger fitness to practice rules. So that is one structured screening, annual well-being assessment using validated tools like IPSSA, overactive bladder questionnaire during routine health checkups will make it more easier. We can detect it little earlier and help the healthcare professional not to treated earlier. So the physician health is patient safety. A well doctor is a better doctor. So, so role of our urological departments, we have, but we should have a dedicated healthcare professional fast track slots where we treat them urgently on fast track basis. And telemedicine is coming in a big way. Where I, being in Apollo teleconsultation, I get a lot of healthcare workers like doctors. We seek their help in under this platform. So peer-to-peer referral networks should be there. So anonymous case discussion in CMEs might help in achieving all these good things. So the key takeaways would be the urological conditions are highly prevalent in healthcare professionals and disproportionately undertreated due to professional specific barriers. The silent suffering impairs clinical performance, leads to burnout, ultimately affects patient safety, and not just personal well being. The effective evidence based treatment exists where overactive bladder, low urinary tract symptoms, prostatitis, recurrent urinary tract infection, interstitial cystitis, if there can be managed well with appropriate care and early diagnosis. Structural change is essential. Confidential healthcare professional specific care pathways and reduce stigma and peer role modeling are all crucial. If a patient had your symptoms, you would refer them today. You deserve the same care. So thank you. Any questions? I'm ready to take.
So thank you so much, sir, for the wonderful talk. And the session was really very informative, sir.
Thank you.
And yes, we have received few questions, so I'll just put it in the chat box. Just allow me a moment. So I've posted the first question.
So that is what the most common urological conditions, chronic urological conditions would be this overactive bladder and recurrent urinary tract infections and lower urinary tract infection like BPH, prostatic symptoms. And the fourth would be this chronic prostatitis, interstitial cystitis, and bladder pain syndrome. These are the common chronic urological conditions seen among healthcare workers.
So that's all we have received, sir. Thank you so much for answering all the queries. And thank you, sir, for joining with us.
Thank you, Team Clarinet, for this wonderful opportunity. Thank you so much.
Thank you, sir. I now welcome our second speaker, BNBM sir. So, are you there? So am I audible to you? Yes, you can join Zoom and we can ask So am I audible to you?
Yeah, you're audible.
So you need to turn on the camera.
Okay. Now I have to upload my slide, right?
Yeah, you need to turn on the camera first. So.
All right.
Yeah. So, sir, as you are the second speaker, after that we have Krishna, sir. So, your
Now I have to upload. Yeah, I have to share the.
Yeah.